Colleagues, we have to continue with the scientific program. I want to invite Dr. Lachezar Dobrichkov, who will present us a presentation named Revascularization of Acute Mesenteric Ischemia, Tailoring the Approach to Patient and Lesion-Specific Factors.
Morning everyone, I'm Lachezar Dobrichkov and I'm a vascular surgeon. Today we're going to discuss the different revascularization techniques for acute mesenteric ischemia. I have nothing to disclose. Actually, we talked a lot about acute mesenteric ischemia. Also, does it work? Probably. Also, Dr. Tsvetkov told us a lot of about that disease. So, in short, I would like to say that it's a life-threatening condition resulting from a sudden reduction of the mesenteric blood flow, leading to intestinal ischemia and potential necrosis. If it's not diagnosed and treated properly and in time, the mortality rates could reach up to 80%. According to etiology, about half of the cases are with embolic origin, most often in patients with AFib. Also, the thrombotic acute mesenteric ischemia occurs usually due to progressive atherosclerotic disease leading to thrombosis. The non-inclusive mesenteric ischemia is caused by severe splanchnic vasoconstriction due to low flow states, often in critically ill patients, and the mesenteric venous thrombosis. This is the rarest one, about 5% of all cases. According to symptoms, the early symptoms are severe and poorly localized abdominal pain, vomiting and nausea, and the later symptoms are peritonitis, hemodynamic instability, and polyorgan dysfunction. According to the etiology, there is some slight differences in the symptoms. For example, the embolic acute mesenteric ischemia has sudden onset and previous history of AFib most oftenly. The thrombotic acute mesenteric ischemia have gradual worsening due to the collaterals, and often proceeding with postprandial discomfort and angina before the acute accident. The non-inclusive mesenteric ischemia is seen in critically ill patient, and the venous thrombosis has usually a subacute course. The CT angio is a gold standard with sensitivity up to 95%. But the conventional angiography is not a bad option for diagnostics too, because it could lead likely to endovascular treatment right after that. So, as any other vascular disease, it could be treated endovascular, hybrid, and open. But as a surgeon, I would like to start with the open surgical approach. So the embolectomy of superficial mesenteric artery is preferred for embolic occlusions. The enderectomy and patch plastic is recommended for focal thrombosis with viable bowels, and bypass surgery is suitable for long segment thrombosis or longer dissections. So the open surgical revascularization is indicated for extensive bioischemia, hemodynamic unstable patients, and failed previously endovascular therapy. Also, in cases of some iatrogenic complications, it's suitable for cases where embolism is suspected, also in cases with primary arterial thrombosis or occlusion due to thrombosis of major mesenteric branches. So the approach to the superior mesenteric artery could be done through a midline laparotomy or upper midline laparotomy. But in our department, we usually do it through a really small upper midline laparotomy, like 15 centimeters incision, using those ring retractors. They're good because they are gentle to the surrounding tissue, also to the bowels. Then the exposure of the superior mesenteric artery continues with retracting the transverse colon cranially and the small intestines caudally. Intraoperative Doppler could be very useful to find the artery. So we open the mesenterium right above the superior mesenteric artery, and the approach is faster and easier. So few demonstrative cases: quite young male obese patient with a history of atrial fibrillation and embolus in superior mesenteric artery. He was operated openly, like in the previous video, and this is the post-op result. Another more interesting case, 80 years old female patient with bifemoral thrombosis and thrombus in the superior mesenteric artery after COVID infection. So after the bilateral femoral thrombectomy, we proceeded with thrombectomy of the SMA. So for that patient, we chose to do a something like remote thrombectomy, going with 19 centimeters a 6 French sheet into the superior mesenteric artery, and from there removing the thrombus using Fogarty catheter. So that method sounds good, but actually didn't work pretty well. Yeah, the videos are not working. So yeah, on those videos you should be seeing that we had a this is the initial angio, and okay, here we see we can see a massive dissection of the SMA. So that led to following open surgery to reconstruct the artery. So in that patient, we did autologous vein patch plastic, and here you can see the post-operative. Yeah, the video is not working again. Thank you. You can see patent SMA after that CT scan is 3 or 4 days after the surgery. About the hybrid approaches, so they combine open retrograde SMA cannulation and stenting. Also, it could be combined with or without thrombectomy, and they are good in the cases of not viable bowels. So the one-stage bowel resection could be performed after the revascularization. The hybrid revascularization is indicated for cases when the endovascular access alone is insufficient or has failed. Which requires surgical exposure. Complex SMA occlusions and extensive thrombotic lesions could be and are better to be treated hybrid. Also, iatrogenic dissections, like in the previous case which I showed, show better results treated this way. So it's suitable for hemodynamically unstable patients, because also the bowels could be checked. Also, the laparotomy is needed for cases in extensive bowel ischemia, and as I mentioned, when the primary thrombectomy failed and another endovascular approach is needed. So approach to the artery is similar, basically the same like for thrombectomy. This case is about 66 years old female patient with acute on chronic thrombosis of the SMA. So she presented with severe symptoms, and for her, this is the pre-op CT scan. For her, upper laparotomy was scheduled, and open thrombectomy of the SMA. Also, retrograde angiography was performed, showing severe stenosis in the ostium of the superior mesenteric artery. So we performed one-stage stenting, and this is the final result. That's the CT scan a couple of days later. Another interesting case, 69 years old male with malposition fenestrated graft during fever. So in this patient, the right renal artery was cannulated and the bridging stent was placed, but the superior mesenteric artery couldn't be cannulated. So that required small laparotomy, exposure of the SMA and the retrograde cannulation of the artery and the fenestration. So here you can see the placing of the bridging stent, the opening, and the final angio. The endovascular therapy is a first-line therapy. Aspiration thrombectomy, we already heard about that, is suitable for fresh embolic thrombi. The most common use device is penumbra. The pharmacomechanical thrombectomy, like angiojet, is suitable for cases in acute thrombosis due to atherosclerotic lesions. And primary stenting is usually preferable with a cover stent, are suitable for cases with fresh thrombus on severe stenosis, or bare metal stents could be placed for high-grade stenosis in hemodynamically stable patients. The indication for endovascular therapy is hemodynamically stability without any signs of bowel ischemia. It's a first-line approach for acute on chronic mesenteric ischemia, and is ideal for subtotal occlusions of SMA and celiac trunk. This is such a case, 65 years old female with previous history of abdominal angina, presenting with acute abdominal pain. The CT scan showed subtotal stenosis of SMA and celiac trunk. This is the pre-op CT, the cannulation of SMA and stenting. Some check, the cannulation of celiac trunk, the stenting of it, and this is the final angio. Patient was discharged a couple of days later, and this is the post-op CT scan 3 months later. By the way, during this time, the patient gained about 20 kilos. So the decision-making, which method to choose, is very important, and we have to ask and answer 3 simple questions. First, is the patient hemodynamically stable? If yes, then we proceed with diagnostics and choosing the method of treatment, and if no, an immediate laparotomy should be performed, and bowel resection is the first step for treatment. In case of bowel infarction, we should do the bowel resection first, and after that the revascularization, and the approach should be chosen according to the etiology. So for the embolic cases, forwarded thrombectomy or stenting with covered stent is preferable. For the acute thrombosis, hybrid thrombectomy plus stenting, or thrombectomy plus stenting, open thrombectomy plus stenting is the best choice. For the non-occlusive mesenteric ischemia, optimizing the perfusion might be enough, and in cases of venous thrombosis, only conservative therapy. This is our protocol for treatment. You can use the QR code, scan it, and save the picture for later and take a deeper look, because unfortunately we don't have the time to take a deeper look in that picture, but as a conclusion, I would like to say that hemodynamically unstable patients require immediate laparotomy, while stable patients should undergo CTA first, and after that the best treatment option should be chosen. The endovascular treatment is preferred in thrombotic lesions in stable patients with focal lesions, while open surgery is better for extensive thrombotic occlusions, failed previous endovascular therapy, or when bowel infarction is suspected. The non-occlusive mesenteric ischemia should be treated medically with vasodilator therapy and resuscitation. tailoring the treatment strategy to patient hemodynamics, lesion type, and bowel viability is the key for treatment. The long-term surveillance and prevention for the embolic acute mesenteric ischemia, lifelong anticoagulation should be considered. For atherosclerotic cases of acute mesenteric ischemia, the risk control is very crucial, like smoking cessation, lipid control, and dual antiplatelet therapy. And for non-occlusive cases, vasoactive medications and their adjustment, also blood pressure optimization and valvular resuscitation. So thank you for your attention.
So thank you, Dr. Dobrichkov, for the interesting presentation. Do we have any questions from the audience? So I want to ask you something. As a vascular surgeon, imagine that we have a case. We used all the guidelines, but we are not sure surgical or endovascular is the perfect for the patient. What would you try as a first choice? Would you try endovascular, or you will go to the surgery?
Well, if you have time and if the patient is stable, I will go for CT angiography first. So we'll have what kind of lesion it is, if it's embolic or if it's acute thrombosis over previous stenosis. So that would be the first step before choosing the most appropriate option of treatment. Another important thing is if we have a viable bowels, and if we have a bowel infarction, we could see that from the CT also. If we suspect any bowel infarction, it would be better to go with hybrid or open, because in this case we have the chance to do one-step bowel resection too, which is good, because if we do the revascularization before the bowel resection in case of a bowel infarction, that might even kill the patient. And hopefully we are working on the same floor with the general surgeons. Some of the cases here were actually their cases before, and so that they paged us and we did them together. So in such cases, if we suspect any kind of bowel infarction or bowel ischemia, it would be better just to start with laparotomy and do it open or hybrid.
Okay, thank you. And something else, when we have successful revascularization, what is your protocol for after procedure check? Do you make some imaging methods like CT or MRI after what period of time after the revascularization?
Unfortunately, we don't have a standard protocol for such cases. First, we don't have they're not that frequent. So we don't have strict protocol for follow-up. But in some of the cases we have, because of the continuing bowel symptoms, abdominal symptoms, we did CT checks a couple of days after the initial surgery or procedure. That was the reason for that. And for example, the last case, that lady had peripheral artery disease, and she had worsening of the claudication. So we had to do another imaging, and so we checked the patency of the SMA and the Syrian trunk, and we did peripheral CT scan, CT angio at the same time.
Okay, thank you. Any other questions from the audience? No, thank you, Dr. Dobrichkov.
Thank you.